All right. I'm going to get started, and if people still trickle in, I'll just admit them as they come. So good evening and welcome to the fourth installment of the AMSNY Diversity in Medicine webinar series. Thank you for joining us tonight. We're excited to have you. Before I get to an intro of our speaker, I just wanted to do a few housekeeping notes just for maintaining order. We want to maintain an open and engaging session. So if you can, we do encourage that you keep your video on during the session. We understand everybody might not be able to, but particularly if you're asking a question, it does help to see faces, and we want to maintain that kind of atmosphere. If you are not speaking, however, please make sure to put your microphone on mute to minimize background discussion. I know I certainly have some things going on, so it can get a little noisy. If you have a question for our presenter, and we certainly encourage you to have questions, you can let me know by putting it in the chat or just indicating that you have a question in the chat, and I'll call on you to facilitate the discussion. Or you could just sort of raise your hand or use the raise hand feature on the sidebar. All right. So again, it's great to see everybody, anybody who joined a little late, and let's get started with a brief introduction from our speaker, Dr. Nana Sarpong. Dr. Sarpong is a New York native, although he did take his talents to Boston for his educational career. He attended Brandeis University, graduating magna cum laude with a degree in biology, and also earned an MBA through a dual degree program there. He then went on to medical school at Tufts, finishing AOA and matching into orthopedics at New York Presbyterian Columbia University back in the city. So we're very happy to have him back in New York, where he's going to stay. He's a chief resident now, but he's matched into an adult joint reconstructive fellowship at Hospital for Special Surgery. So he also says that his favorite bone is the tibia, and he likes to operate to Phil Collins, which we can get to later. But welcome, Dr. Sarpong. Thank you so much for joining us tonight.
Thank you so much for having me, Jenny. I'm looking forward to this meet and greet, and hopefully it's an informational session for everyone.
I agree. So knowing what we know about you, a lot of our students here are either in their post-bac and attending medical school next year or are currently in medical school. And so I was hoping you could tell us a little bit about your journey to both medicine and to orthopedics as a specialty, and what led you to be interested in it and what made it ultimately your choice.
Got it, yeah. So I went to, like Jenny alluded to, I grew up in New York. I actually went to high school on Upper East Side on 96th Street between 1st and 2nd. At that time, it was a smaller high school. I think they had only graduated 3 classes, but it was called Life Sciences, and it pretty much catered to people that were interested in the sciences. And, you know, in middle school and elementary school, I always loved the sciences. I didn't have any physicians in my family. But my mom worked at a hospital. She was a vascular sonographer. And so when I was younger, I'd spend a lot of time, you know, going to meet her after school, you know, while she's at work, waiting in a waiting room and things like that. And, you know, I was exposed to it. And so while I was at Life Sciences, I got a chance to do a program over a couple of the summers, basically a summer science immersion program. And, you know, I volunteered in the emergency room and ICU as well. And so fast forward, I attend Brandeis through the early assurance program at Tufts. Sorry, early decision program through the Posse Foundation. And pretty much when I was there, you know, I focused on biology as a major, but, you know, obviously taking pre-med classes, you know, with a goal being eventually become a physician. There was this early assurance program that Brandeis, not just Brandeis, but Brandeis, Boston University, Northeastern, and a couple of other schools around Boston pretty much had a pipeline with Tufts. And so I was able to do that program, an early assurance program, by taking biology, organic chemistry, physics, and general chemistry by the time I was a sophomore. And basically what I did was I applied to medical school at Tufts as a sophomore at Brandeis. And I was lucky enough to be admitted into med school through their early assurance program without having to take the MCAT. They gave me the option. Pretty much they said, you know, if you wanted to have the opportunity to apply to other medical schools, you can take your MCAT, you know, by the time you're a senior. But, you know, to me, it was a no-brainer. Basically, the benefits of not having to study for the MCAT but still, get a spot at a grade A in a top tier medical school like Tufts for me was a no-brainer. And I had no interest in taking or studying for the MCAT. And so I went ahead and, went forward with that and loved every second of my time at Tufts. I kept an open mind. I thought I was going to do anesthesiology, just because one of my best friends from college, from Brandeis, his dad was an anesthesiologist, and I got pretty close to him. I got a chance to talk to him about what he does. But ultimately, I got through my third year, which essentially is a bunch of mini clerkships, and I got a chance to do electives in orthopedic surgery, urology, and plastic surgery, and I loved all the surgical subspecialties. And I did 2 weeks each on those various subspecialties, and fell in love with orthopedics. And so during my fourth year, decided to do rotations. Basically, during your fourth year, depending on what you're going to, especially if it's a surgical subspecialty, you do a month at various institutions. And so I ended up doing a month at Columbia, which was my first away rotation. And obviously having family here, it was ended up being home for me. And so I got a chance to see family when I was at home. I was rotating here at Columbia, fell in love with the department, the faculty here, and all the opportunities that come with it. And for me, it was the perfect match. And, I put it as number one when it came down to ranking my residency programs. And again, the theme here is I've been lucky many, many times. I got lucky again. I matched on my first choice. Got to Columbia, again, kept an open mind, loved every single subspecialty, hand surgery, hip and knee replacements, like spine surgery, pediatric orthopedics, sports medicine. But ultimately, I jived the most with the hip and knee reconstructive guys. And, they ended up becoming my mentors and, friends and people that I can, go to for mentorship. And so, and I like the procedures a lot. To me, it made sense. It was a way to, hip and knee replacement is a way to master one thing through multiple reiterations. And, there's a nice mix of technology with robotic procedures. There's a lot of, new technology involved, but also you can get creative with revision and complex arthroplasty. And for me, it was a perfect mix of being able to become really, really good at one thing, but also having a variety when you do want it. And so, yeah, I loved the hospital for special surgery, as Jenny had alluded to before, during my fellowship trail. And, it's obviously one of the best institutions for orthopedic surgery around the world. And so, again, lucky to have matched there. And yeah, I'm looking forward to them in my last year of orthopedics residency right now here at Columbia. And so that's why I was invited to hopefully share some of what I've learned along my way.
Great. And for all of the participants here, please, if you have any questions, have them keep coming. So you mentioned the importance of mentors and some of the people in your program who have helped guide you along the way. When our students are going through the process of looking, what are some things that sort of made you feel comfortable? What are the things they should look for? Should they just trust their gut, or are there certain academic criteria maybe they should be looking for when they're evaluating a program or knowing whether it's the right fit for them?
Yeah, it's a great question. I think for me, ultimately, it came down to a gut feeling, being there, talking to as many people and vetting out these programs for yourself. Obviously, we're in some strange times right now where you can't be there in person and get a feel for it. But I think the most important thing for me was having people that you were going to be able to rely on, people that were going to be able to advocate for you when you need help, in your career. Medicine is not an easy field. And, for me, the people that I met during my time at Columbia, resonated and struck with me a lot. And so, yes, obviously location means a lot, but at the end of the day is, who are you going to be able to pick up the phone and ask for help and, have that help be given to you when you need it. And, that can be in the form of, like I said, gut feeling. It's not always the person that looks like you. It's just through, multiple interactions, having similar interests. Person doesn't necessarily have to look like you. It makes it easy, but it's not mandatory.
That was one of my other questions. Surgical subspecialties, in particular orthopedics, have low URIM matriculation. Is that something you found both difficult, or maybe it was something that encouraged you? And what would you say to somebody who is interested in a specialty where there aren't as many underrepresented students, and how would you encourage them to either go for it or maybe hold back or choose something else?
Yeah. So yeah, as we know already, the medicine in general is not as diverse as we want it to be. The goal obviously is to match the physician workforce to our patient demographics, and that's not the case. And then let alone when you get into the surgical subspecialties where it becomes more and more competitive, people kind of get deterred. And so for me, my personality has always been, do something that people don't think you'll be able to do and go for it and prove people wrong. And that's just how I've always kind of approached my life, and, doing things that no one else is doing, or things that people didn't think you'd be able to do. And so, yeah, I always, I mentor people all the time. My little brother's an orthopedic resident at NYU right now. And obviously, he's a couple of years behind me, but, he's like, even within orthopedics, like in spine surgery, for example, there are not a lot of underrepresented, minorities in spine surgery. And so like, he's thinking about that now because we talked about it.
Great. Another thing I was saying is women tend to be underrepresented in orthopedics as well. And so that's something, when you talk about finding a mentor who maybe doesn't look like you, for someone who maybe is a woman but is interested, what kinds of things would you recommend to them to reach out to people who maybe aren't the most identifiable mentor, but what are some things that you have done or programs that you know of to help people find those mentors who maybe don't look like them, but are people who are willing to help?
Yeah, absolutely. And we have several programs like that we're a part of at Columbia, and I'm happy to share that with you guys. The Perry Initiative is one of them. And that essentially, Dr. Perry was one of the first female orthopedic surgeons in this country. And every year, Columbia is a co-host for this Perry Initiative, where we invite high schoolers and pre-med students from all around New York to participate in sawbones, anatomy, cadaver sessions, just to get them ingrained and get some nice exposure. Because like you said, as part of the diversity thing, it's not just a race thing. Gender is also a big thing. And so, you look at orthopedic surgeons, most people are old white men in orthopedic surgery. And so we're trying to, like I said before, have our physician workforce basically become or try to get as equal to our patient workforce. And so that's one example. Nth Dimension is another example of a program that tries to immerse, underrepresented students into the field. And I'm happy to share both of those resources if people are interested.
That would be great. I should mention that we actually got connected with you through the New York Society for Orthopedic Surgeons, and that is something that they look into. So if people are interested in opportunities like that, we're happy to facilitate any connections as well. All right. Does anyone have any questions before I'm happy to keep going, but. You also have an MBA, and I was interested to know how you planned on using that going forward, or ways in which that has helped you throughout your career. It's an interesting combination. And if somebody were considering it, would you recommend that they do a dual degree, or maybe not take the time to do something like that?
Yeah, no, excellent question. And so I did the MD MBA program. At the time, it was like 2009, when I was accepted to the Tufts Early Assurance Program. And it was a 4-year program. And Tufts and Brandeis had this opportunity where you can do an MD and an MBA as part of your medical school training. And basically, it was all going to be able to be done in 4 years. Most MD MBA programs are 5 years. And so that means you're taking some extra time off to pursue your MBA. And so for me, I thought around that time, the Affordable Care Act was being rolled out, and a lot of people didn't really understand. A lot of physicians didn't know how to navigate those hoops. There was a lot of talk about pay for performance and pay for quality. And it turned out that a lot of people who were making up these performance measures and these benchmarks were people who were not physicians, who were people, essentially business people, who sat behind desks. They don't really know what it's like to struggle with a patient, deal with sick patients with multiple medical comorbidities. And so to me, I thought at that time that if, having that extra knowledge, to be able to be well versed in both medicine and business, just to give me a seat at the table, would be beneficial. And obviously in residency, you're focused on one trade, which for me now is orthopedic surgery. And so I'm not using the skills, the organic, not the organic, but the more, how do I say this? I'm not using the hard skills that, I picked up in business school. So i.e. accounting, financial accounting skills and things like that, but every day I use my operations management, my leadership skills, my negotiation skills when I deal with patients, when I deal with, residents as a chief resident this year. And so, I'm using it in, many capacities, although it's not necessarily, it doesn't feel objective. It's more, I'm using the softer skills now, so to speak. And as far as where, what I see myself going with it, I can essentially, it can be anything. If I end up pursuing academic medicine, which I'm probably on track to do, it's going to give me an opportunity to take over more leadership roles and administrative roles. And, if I decide to pursue private practice, I understand how to manage a business because, I've taken many business classes. I know how to balance a checkbook, and things like that. So it gives me the chance to be volatile.
Great. Jesse, I believe you had a question.
Sorry,
yeah, go ahead.
Sorry. So first question was, did you engage in any extracurricular activities while you were in school? And then if you did, like, what would you recommend now, or how would you recommend balancing that with like academics? And then the next one was about an MBA and how affected your time in school. Does it prolong it, or can you do it side by side? And how does it, I guess, the pressure of doing that, how does that impact your life outside of school?
Yeah, all great questions. So yeah, extracurricular, I think it's important to, not just be stuck in the books. I think it's good to have hobbies because it's nice to decompress. Otherwise you drive yourself crazy. When I was in college and all throughout medical school, I was involved in multiple sports. I played a lot of intramural baseball. I played basketball. And so that kept me busy. It was a nice way to decompress. I loved my time in Boston. I met a bunch of friends. A lot of my friends ended up staying, in Boston after we graduated college. So even when I was in med school, I still got a chance to see them all the time. And, we did a lot of trips, traveled a ton. And then your other question was, MBA. So like I said, it was 4 years. I didn't have to take any extra time. I think a lot of the MBA programs, MD MBA programs now are either 5 years or 6 years. And so I know Harvard, for example, has you take 2 years off. I spoke to a student recently who's thinking about it, and the HBS, you have to take 2 extra years. And then before coming back to med, he's a third-year medical student now, and he wants to do 2 years and come back. So that's 6 years. That's fine, depending on what you're looking for. Obviously, if you go to Harvard, it offers you a lot more connections than I did. I wasn't looking for that. I want to practice clinical medicine primarily. If you're the kind of person that wants to do, you want to go into consulting, go work for Johnson & Johnson, go work for Goldman Sachs, but in an MD capacity, then yeah, it might be beneficial to go somewhere like HBS. But for me, I wanted my MBA focus was in health policy, health management. And so, 4 years was a no-brainer, no additional time. And it's exactly what I wanted. Hopefully that answers your question.
Great. Bianca, I believe you also had a question.
Jenny?
Yes.
If I may, before we go on, as students are asking questions, and Jesse, if we can do this starting with you, just let us know, let Dr. Sarpong know, and the rest of us, if you're currently a post-bac student and where, or if you're an alum and you're now a medical student, and what year you are, and if you're interested in orthopedics, so that he can get a feel for the audience.
Yeah, that'd be great. Thanks, Bertia. Yeah.
Sorry. So I'm in the post-bac program right now, first semester. As far as specialty, I was thinking general surgery, but I'm not decided. I'm keeping an open mind as of now.
Cool. That's great. Yeah. I think if you're the kind of person that's, you know, results driven, and Jenny can tell you, you know, her husband's an otolaryngologist, you will gravitate towards surgery, because in surgery you have a defined problem and you're able to address it and see results right away. And if you're that kind of person, then, you know, I think definitely you should pursue surgery. I mean, it's not always clear cut, but, you know, if that's your personality, you'll find yourself gravitating to that when you get to medical school.
Hi, everyone. My name is Bianca. I am a post-bac alum and I'm a first-year med student. I'm
Congrats.
also interested in, thanks, you know, it's a grind. So I'm also interested in surgery. Not particularly sure just what, but like I do like ortho just because of my experience in the past with it. And I was just wondering like what suggestions you had for like engaging in research, number one, but also like finding mentors, because it's a very like male dominated field, which I'm like not opposed to, but I think like finding mentors who kind of have to deal with certain things that women have to go through, I think is difficult. So I just wanted your thoughts.
Yeah, no, absolutely. And, you know, obviously take everything that I say with a grain of salt. You know, my comment earlier about not necessarily finding people that look like you. Yes, that's true. But at the same time, like you were saying, there are not a lot of women, you know, in surgery. And so if you find someone who, you know, who's going through, or who went through if you find someone who went through what you're going to be going through, who can tell you what it's like, you know, the hoops and loops that they went through, I think it's helpful. What medical school are you at?
I'm at Rochester.
Got it.
University.
And so, you know, we have Dr. Wakenda Tyler, for example. She's an orthopedic oncologist. She was at University of Rochester for a long time before she came down to Columbia. You don't find too many orthopedic oncologists, and that's a long grind. You know, she does long cases, 12-hour cases. She's usually the chair for the Perry Initiative workforce thing that I was telling you about earlier. So, you know, finding people who, that doesn't have to be, you know, Dr. Tyler's one of the nicest people that I know. You can shoot her an email, cold email, and you'll find that people are willing to help out. I can't tell you the number of times people reach out to me, and, you know, even though my life is busy, I find time to pay it forward, because people did that for me, you know, when I was in your guys' shoes. And you'll find the same, you know, you're first year medical student now, you're going to have high schoolers and college students reaching out for you, and you just have to pay it forward. And people are willing to help out more than you think.
Thank you. Also, if you could kindly, when you have a moment, type in the name of the Dr. Tyler.
Yeah, absolutely.
Thank you.
And, you know, I think, especially at your stage right now, you know, as a first year medical student, you're open-minded, and people like that. You know, if I have a first year medical student reach out to me wanting to shadow me, I would be very, very open to that, because if I can influence you and feel like I'm, you know, making some kind of influence on your life, it feels good on the other end. You know, I think people are more open to it than you think. And don't feel bad. You know, we've all been through it.
Yeah.
Shoot a cold email, especially.
Thank you.
Yeah.
I could also say from experience that people who are in sort of a subspecialty are generally very enthusiastic about it. So they want to bring you in. So I echo that to reach out to people, and, you know, usually you can find someone who's willing to talk to you and talk your ear off about whatever they do for a living.
Exactly. And one thing can lead to another. You know, you can get research opportunities that way. If, you know, he or she, you know, has projects ongoing that they need help with, you can get your name out there that way as well.
Luna Maria, I believe you had a question.
Hi, everybody. My name is Luna Maria. I'm doing the post-bac program right now. And hi, thank you. As far as I know, I'm not interested in surgery, but I do wonder, first of all, do you know that you wanted to do surgery from the very beginning? As in, was that like a gut feeling that you already knew? And second of all, my question has to do with actually doing residency in Washington Heights community. I am interested maybe in working there or in the Bronx, but I also wonder how will that impact my ability to interact with different patients coming from all over the world. And I just wanted to hear your experience.
Yeah, absolutely. So the first part of the question was, how did I pick surgery? And so when I first got to medical school, I think I was interested in anesthesia because I had a really good friend whose dad was an anesthesiologist, but I quickly learned that for me, being able to, see a problem and tackle it, I saw that more in surgery. And so I gravitated towards surgery, not necessarily knowing what kind of surgery. Ended up being that I ended up loving orthopedic surgery, but I kept an open mind. I loved every single rotation during my third year. And then your second question about Washington Heights and Columbia, it's nice because at Columbia, we get a nice potpourri of patients. Yes, we get the Hispanics who are, from the Bronx and, from the Washington Heights area. But at the same time, people are coming from all over the world. And so I think it's been a nice mix for me being, able to navigate people who don't have, the best means, but also people who are coming from really good means. And, ensuring that the quality of care is not different. We talk about healthcare disparities all the time, and you see it happening sometimes. And so it's a nice dichotomy that we see sometimes. I think it's a great place to train if you're interested. Washington Heights is an amazing community. People, I love taking care of the people from that community. In fact, we have a clinic that I just got home from. It was a resident-run, hand surgery clinic, and most of the patients, out of 60 patients, probably 45, 50 of them are from the area. And it's nice to, give back to that community.
Christiana.
Hello, my name is Christiana. I am currently a postbac at the University of Buffalo.
Cool.
My question is, can you give a quick snapshot of what your daily life looks like, or share an interesting case or patient interaction that you've worked on so far?
Yeah, cool. So my day changes on a daily basis, but for example, today I was in clinic, and so I didn't have patients to round on, but if I had patients to round on, I'd go to the hospital, round on the patients before going to clinic. I'll tell you about a more typical day. So on Monday, for example, I had a couple of patients to round on, and so I got to, and granted, a lot of things have changed because of COVID. We're not really doing conferences in person. And so generally I would get to, pre-COVID, I would get to the hospital, anywhere from 5:45 to 6. We'd have conference at 6 a.m. looking at trauma cases. So any consults that came in from over the weekend, we'd look at it on Monday mornings, and the junior resident would present all the cases that they saw over the weekend. And we talk about it, as a senior resident. I would ask them questions and we go over cases together. Cases generally start at 7:15, 7:30. And so I usually round on patients, go to conference, grab a quick, 5-minute breakfast before cases start 7:15, 7:30. And, depending on how many cases you have during the day, that could be anywhere from, 2, 3, or 10 p.m. sometimes. And then, usually you round on your patients, you do post-op checks on them, and then you come home. And if you're not exhausted, then I try to make it a habit to read, whether it's a journal. We just have our entrance exam this past Saturday. And so, I spent a lot of time studying for that when I came home from work. That's how a lot of my time is spent right now. And on days that I'm not operating, I'm in clinic seeing, patients that we've operated on, or patients who might need surgery.
And just a follow-up question. Thank you for that, actually. As you are the chief resident, correct?
Yeah, that's correct.
So what skills do you think allowed you to succeed in this role, and what skills do you look for in your junior residents?
Yeah, fantastic question. It's kind of like the skills that I was alluding to earlier, skills that, might be innate, but also skills that I might have picked up in business school. And so the softer skills, being able to negotiate, not necessarily contracts, but, deal with so many different personalities. I have 30 residents that on a daily basis, I have to navigate different personalities, and, people are upset all the time because, you're not always giving people what they want. But being able to be okay with that, be as objective as possible, not emotionless, but trying to be a fair leader. And, through my various leadership roles, it wasn't something that I volunteered for. It's a voting, I was voted the chief resident, myself and, my co-chief, Carl. The faculty and, the co-residents vote, and people felt that, we could get the job done. And yeah, I think a lot of it is innate, having natural leadership abilities, but also I think I picked up a lot of it somehow along the way through, business school, the softer skills like I was talking about. Hopefully that answers your question. Yeah.
So as we're talking about some of the skills that might be attractive in a resident and a chief resident, with COVID changing things and you don't really get that away rotation experience anymore right now, what could students do, and what would you look for in a student who is doing sort of a virtual rotation? Or how can students sort of stand out? What are the things you're looking for in the sense that like you're not getting that time to get to know people? I think there are a lot of virtual interview, like even if you're asking to do a shadowing experience, what are some of the things that people could display that would make you say like, I want you to come here and work with me?
Yeah, so we're unfortunately having to deal with that, and I'm sure your husband will tell you they're probably dealing with that in their residency as well, not having the benefit of having students in person. And so at Columbia Orthopedics, we've developed this thing called the Columbia Longitudinal Informational Program, CLIP, which is essentially a longitudinal program which started in July, which is generally when our away rotators would come in person to do rotations. And it gives the students an opportunity to get to know us. And so what we do is we match each student to a resident buddy or two. And so it's on that student and the resident to keep up the interactions, not over 1 month, because I think, in my opinion, that's meaningless, but over, 4, 5, 6 months, and really get a deep dive in the program. And so I have 5 CLIP buddies that, I talk to on a regular basis, check in once a week. And then beyond that, I found that the people who are really, really interested in my program at Columbia are the ones who are not necessarily assigned to me, but reaching out to get my perspective on different things. Again, my perspective as a chief, as an outgoing resident, have I enjoyed my time here? And do I think, would I do it all over again? So people going above and beyond, like we talked about before, reaching out. People are always happy to answer your questions. You can be a busy person, but, you'll make time for it because it's a nice way to give back. And so, yeah, I think, reaching out and finding programs. I think most residencies are doing that right now in the COVID era. Like I said, my little brother's a resident at NYU, and, they have a very similar program as well.
Great. Also talking about COVID, I mean, orthopedics is a specialty where a lot of the things might not be, essential surgeries. And I was curious as to what your experience was like during sort of the height of the pandemic. I mean, obviously Columbia was, one of the epicenters. And, I know a lot of people got pulled from the floors, and I was curious as to what your experience was like, and also what you learned from that, and maybe what our students could take from, sort of having their lives turned upside down in that way, and how you move forward through something like that.
Yeah, I'm going to just quickly share a link for an article we published recently about orthopedic surgery redeployment during the COVID-19 pandemic. Basically, as Jenny just said, we lost a lot of our ORs at Columbia. We became a hot spot. And so what happened was we weren't doing elective surgery anymore. And so all our ORs were converted to essentially makeshift ICUs. And so that meant that, we were essentially redeployed. I just sent that link to the ICUs, to the emergency rooms, helping our emergency room colleagues, helping the ICU doctors take care of the sick patients. Because, we're not doing elective hip and knee replacements. We're not doing ACL reconstructions, scoliosis surgery anymore. And so it really forced us to be, versatile and use skills that we hadn't used in a long time. I was in IC in the emergency room. I hadn't done that since I was an intern 4 years ago. And, it was the thick of it. You were literally in the height of the pandemic, in New York City, as you all know, New York City was the epicenter. And yeah, but we got through it. Now we're probably back to 80–85% of our capacity, and we're, feeling the start of a second surge. And our chairman just sent an email the other day saying, don't lose your guard, keep wearing your N95 masks, protect yourself. So we're feeling it right now. I don't know if we're going to be canceling. I mean, patients are already, I'll tell you right now, patients are adamant about coming into the hospital for elective surgery. No one wants to come in and get exposed. And so we're already starting to see a decrease in our numbers. But, around March, April, we stopped completely elective surgery. And I did, a lot of ICU shifts and, emergency room shifts. And so I was intubating patients, starting lines, putting in medications I hadn't put in a long time, literally actually practicing internal medicine and ICU level medicine and emergency medicine. And I think, it's part of, as a physician, you have to be ready to do that. It's our calling. And you get trained to do that, to be able to, jump between different disciplines if society calls for it.
Great. Joe, you have a question.
Fantastic question, Joe. So it's a hard question. I think
very difficult. It's a very difficult question.
Exactly. Just the way my career trajectory is going, Joe, I think, from Tufts and, just my interest in teaching and mentorship and research, I think I'm just de facto probably going to pursue academic medicine. But the reality is there are not enough academic medical jobs available. You look at it, most orthopedic residents coming out of orthopedic trainees coming out of fellowship end up going with a private practice job, just because you can imagine that people have, tenure. People are, become tenured faculty in a position, and the throughput and their turnover isn't that high. People aren't leaving every couple of years in academic medicine. And so that lends itself to mostly more private practice jobs. And so, right now there's a pandemic, there's almost like a hiring freeze in a lot of academic departments. So people really start looking during your fellowship year. And so that's next year for me. So I have some time to think about it at least.
So
if I was going to answer your question right now, it'd probably be, either academic medicine or what we call a hybrid, which is privatedemic. So a nice hybrid of private practice and academics.
So what are your research interests, and how did you, move into those sorts of interests as you were going through your medical school and residency?
Yeah, absolutely. So I enjoy doing mostly clinical research more than the basic science stuff. And I like to study patient-reported outcomes that, can help us make decisions for our patients. So really practice evidence-based medicine. And so one of the projects that I'm proud of right now, for example, in total knee replacements, in total hips, we've mastered it. There's like a 99.9% satisfaction rates in patients undergoing hip replacement surgery. When it comes to knees, total knees outcomes, it's like a 20% dissatisfaction rate. And there's so much room for error. And, traditionally orthopedic surgeons and, knee surgeons have balanced knees using more subjective means. And so, you're able to feel a knee and, you can say, okay, it feels like, it's tight or it's not tight. It's very subjective. We didn't really have any objective ways and modalities to assess it. And so there's this new technology, not that new, but relatively new, called an ortho sensor, which is a balancing device, which allows you to essentially quantify the pressure loads in the inside and outside of the knee when you're performing a knee replacement. And some surgeons feel that if you can leave the operating room, if the patient leaves the operating room with a better idea of the balance, that might lead to, better long-term function, longevity of the implant. So I'm studying that right now. I'm doing a randomized control trial where one arm of patients are undergoing knee replacements with this device, and then the other arm, basically a coin flip without. And, I'm comparing outcomes at 3 months, 6 months, 1 year, and 2 years. And I'm looking to see if there's a difference at all. And so far, it hasn't really panned out. There's no difference at all. So I'll keep you posted if I start to notice a difference.
I have a quick question.
Yeah.
Good evening, everybody. My name is Timmy. I'm a post-bac student. So,
welcome, Timmy.
Thank you. I wanted to know if orthopedic specific research was essential to your application when trying to match. And I wanted to know what were some qualities you would look for in an aspiring orthopod.
Yeah, absolutely. I think it's a very mature question. So orthopedic surgery is unfortunately one of the more competitive subspecialties. I think, orthopedic surgery does that to kind of prevent oversaturation of the field. And so exactly what you just said, research is really what research and obviously your third year grades, I think, are probably the two things that I would say right now, which makes students stand out. Because everyone, especially, by the time you guys apply to residency, step one, the USMLE step one is probably going to be pass fail. And so the only other ways to really stand out is your performance during your third year clerkships. And so, are people saying, Timmy was consistently, an honor student. He was hungry. He came in first to show up for rounds, last to leave. Are people consistently saying that about you? And, what are you doing? Are you showing dedication to the field by doing research, right? And that's how people are standing out. So that would be my two top recommendations if you're trying to apply into orthopedics residency today. And, obviously I review a lot of applicants now as a chief, being on the other side. And that's the two things my chairman, Dr. Levine, looks at: consistency. And, obviously if you're a stellar student, that we're going to see that in your letters of recommendation. But I think for us, the consistency with the third year clerkship evaluations and, your productivity, it doesn't have to be orthopedic research, by the way. Just having a knack to find a research question and being able to tackle it with a project and being able to see that project to completion is nice. And, there's some studies that correlates to clinical success and, academic powers when you end up coming into residency.
Thank you.
So I know you've alluded to this in a couple of different spots, but I was curious, for people who maybe know orthopedics, sort of, it's about bones. What are some of the subspecialties? You're going into reconstructive joints. What are some of the other areas where you might not necessarily think like, oh, that's orthopedics too? Something to sort of flesh out the field.
Yeah, absolutely. Because the people hear orthopedics and they think it's either a podiatry, or I don't know, like physical therapy or something. So the different subspecialties within orthopedics are adult reconstruction and joint replacement, which is what I'm going into. There's spine surgery. And so that just means, anywhere from adults with scoliosis or adults with, degenerative spine disease who need some kind of decompression, basically arthritis in your spine and your nerve roots are being compressed. Sometimes adults have scoliosis or kyphosis, and it's really affecting their quality of life, and you have to do some kind of deformity correction surgery for that. So that's spine surgery. Foot and ankle surgery deals a lot with and actually in New York City there's a little bit of overlap between podiatry, which is a totally separate field, and school. Foot and ankle surgeons are allowed to do foot and ankle surgeons do ankle surgery in New York, whereas podiatrists are not allowed to do. They're only allowed to do procedures about the foot. And so, foot and ankle surgeons are doing ankle fractures. They're doing Achilles repairs. They're doing a lot of bunion surgery, tendon repairs around the foot. There's orthopedic trauma, where you're working at a trauma center and you're taking, level 1 trauma call, you're dealing with high energy motor vehicle collisions. You get a lot of pelvic fractures and acetabular fractures, hip fractures, long bone fractures, patients and extremists, polytrauma patients that you're dealing with. So if you like that high paced life, that's a good option. Sports medicine surgery involves a lot of athletes and weekend warriors. And so, taking care of patients with, ACL, meniscus tears who need reconstruction or repairs, taking care of a lot, at Columbia, we're the team doctors for the Yankees, the sports medicine department, we take care of the Yankees. We see a lot of elbow and shoulder issues that, we operate on using cameras inside the joint. So minimally invasive surgery. Pediatric orthopedics. And so, you're dealing, again, there's a subset of pediatric orthopedics where you're dealing with kids with scoliosis who need deformity surgery, but also a lot of, congenital deformities that kids are born with that need corrective, surgeries for, and osteotomies. Within pediatrics, you can do trauma. And so, you're seeing, especially in the summertime, kids falling off monkey bars, kids getting, wrist fractures and elbow fractures. And so as a pediatric orthopedic surgeon, you'll be able to manage all of that. There's hand surgery also, which is the rotation I'm on right now. And so that could be dealing with fingers, dealing with the wrist, dealing with the elbow. And some fellowships actually allow you to deal with the shoulder within your hand fellowship as well. And so the overwhelming majority of patients that I saw today, for example, in clinic had trigger finger, which is essentially when your finger gets caught in this position because there's such a tight band going across your flexor tendon, and that sometimes needs to be released if you can't get better without an injection or therapy. There's carpal tunnel syndrome. And then obviously there are finger fractures and, tendon conditions around the elbow, wrist, hand as well. And let's see, am I forgetting anything else? I think that's about it. I've talked about, most of the subspecialties, if not all of them.
Oncology?
Yeah, orthopedic oncology, exactly. And so, dealing with, bony tumors and sarcomas, soft tissue sarcomas that invade the musculoskeletal system. And so Dr. Wakender Tyler, who's one of my mentors and someone I really, really look up to, that is her focus. And so, she manages all of that. And that's, if you're the kind of person, you want to deal with the patient as a whole, deal with the cancer stuff, work with the medical oncologist and the surgical oncologist, and sometimes the radiation oncologist, that field might be for you.
Great. Bertil.
So yeah, lots of options within orthopedic surgery.
Possible.
They make fun of us as we get called carpenters a lot, but you have to know your anatomy. And at the end of the day, it's usually people who want to see results, people who like working with patients who are motivated, who want to get back to their activities of daily living or their sport, back to their life.
So Dr. Sarpong, I have a question. Hello, my name is Bertil. I'm the Director of Diversity at AMSNY. So Jenny and I are co-partners in this.
Awesome, thank you for having me.
Thank you for being here. So as a follow-up, since you were talking about how important, there are certain specialties, right, that doing a year of research really, helps you stand out, and is almost important to do if you want to have a shot at that specific specialty. And you talked about ortho being one of them. So how do you, I typed it up in here, let's see. Typically, when do medical students take the time to do research? Even, is it typical? How many, is it a large group of med students that do this? And for how long? Is a semester long? Do you do a year long, more? And how do you recommend to even begin this process?
Yeah, absolutely. So I think in 2020, 2021, the competitive specialties that might require research, and I'm sure you guys are going to hear the perspectives of the other residents and physicians who are going to be doing similar webinars, are, orthopedics, otolaryngology, plastic surgery, dermatology, ophthalmology. If you're interested in any of those, they probably want to see some kind of research or dedication to the field. As far as how to get involved, I mean, you can get involved. It doesn't have to be, people, there's a myth going around that you have to take, 1 or 2 years. You can do it while you're in medical school. And that's what I did. I sent literally a cold email saying, hey, I'm not a first year medical student. I'm interested in research. I see you do this research because I looked them up. Would you be willing to talk to me about some of your projects? And, that was more of a longitudinal experience because I was a first year when I got involved, and, that progressed to, by the time I was a fourth year, I had a couple of projects. And so if early on, I think it's helpful, but it's not necessarily mandatory. And, we see people all the time who come in with one publication, not necessarily in orthopedics, but, they're able to carry out a project from start to finish. It's not mandatory to take a year off to do research. If there's a specific project, you want to pursue a randomized controlled trial, that's going to take time, and you want to be the lead author and principal investigator, then that might take more time than doing it as a side project while you're in medical school. But it really depends on what what the project is, what you're looking for, and what you're trying to achieve. I don't want to give a canned answer because everyone looks different on paper. And so if you're the kind of person who is an average student, you might benefit from maybe taking a year off to show more dedication to the field. But if you look good on paper, you're a star, all your rotation, you got clinical honors on, everyone has great things to say about you, you might get away with, just doing a few side projects. And so you have to be honest with yourself and, figure out what kind of candidate that you are. But it's not mandatory. If you're going into any of those specialties that I talked about, you don't have to take a year or 2 years off to do it. You can do it while you're in medical school. And like I said, if early on, it's helpful to reach out to people and, get your name out there and get your name on projects early on.
And this individual that you might reach out to might become a mentor of yours, right?
Exactly. And then you get to form a, longer lasting relationship that way because, you were first year or second year when you met them and, you're fourth year now. One of my mentors, I'm PGY, I'm a fifth year resident now. And I met him when I was a second year. And I run into him at these conferences for hip and knee replacements all the time. And, we get to catch up and we've been friends, it's been 8 years and, we still keep in touch every so often. So you get to build, nice friendships and relationships that way.
Great. Does anyone else have any questions? Jonathan?
I have one last one.
Oh, wait. I'll let Jesse go first.
Yeah, Jesse, please.
Staff.
So if you could go back to med school, like today, what's one thing, or can you give me 3 things that you would change or do better, or if there's none too, that's fine. But what would you change? What would you do better? What would you improve on?
Yeah, that's a hard question. Wow. What would I do differently in medical school? Yeah, so listen, as I talked, I discussed with you guys before, I've been very, very competitive with myself my whole life. And the curriculum for at least the first 2 years of medical school, and I think most medical schools, a couple of you guys are first year medical students, pass fail. For me, it wasn't. I was going so hard. I wanted to ace every single test. I wanted to be in, 100th percentile every single test, and I didn't need to be. And, I'm not sure if that made a difference clinically at all, but that's just, maybe I should have spent more time, having fun, spending more time talking to my family. I think those are all things that are important that, I tried to stress. And I'm probably not, the best person to be given this advice because I don't talk to my family enough. I don't spend enough time with my, my significant other, than I should. And looking back, I probably, there are things that you can kind of sacrifice. And that's one thing that I can pinpoint, when you have a pass-fail system, you don't have to kill yourself, and go for the platinum every single test. But again, that's just, I'm competitive with myself. That's one thing that I would change. Hopefully, I don't know. It's a tough question, but that's what comes to mind right now.
All right. Jonathan, was that your question?
No, Jesse's question was much better than mine. Mine's a softball question. Actually,
a hard question. Yeah, that's a hard question he gave me.
Yeah, this is an easy one, sort of a psychological question. Jonathan Tan, by the way, I'm the COO of AMSNY.
Awesome. Thank you for having me.
Thank you for being here. I mean, this is great. This is awesome. So my psychological question is Phil Collins. So is this strictly an OR thing? Like, is your affinity confined to the operating room, or, you know, and does it put you in the right headspace for operating?
I just find it to be so soothing. So one of my chief residents from when I was a first year, he was a fourth year, and he would always listen to it. We'd be doing cases together, and every case would just go so well. And so I made it a habit. And to answer your question, it started off being just an OR thing. But, you know, my girlfriend will tell you that I listen to, you know, Phil Collins all the time, and people make fun of me for it. Yeah.
I mean, my question was in the air tonight or a studio, but I feel like the students might not.
Yeah, we might be outdated. We might be dating ourselves with that. Yeah. I like One More Night a lot. Actually, I remember it was one of my last nights as a second year resident. In ortho residency, your second year is your hardest year, and I was on night flow, and I remember, like, my last night shift ever, I had that song on repeat. One More Night, just literally playing on repeat the whole night.
So I think the takeaway here is that everyone should become a surgeon, so that when you're a chief resident, you get to pick the music. That's really
exactly. That's the big takeaway.
Power move right there. That's the reason to go into surgery. Any last questions now that we've gone on our musical digression? All right. Well, thank you all for joining us. Thank you, Dr. Sarpong, for taking time out of your extremely busy schedule to come talk to us. We really appreciate it. And thank you all. Have a good night.
Yeah, thank you kindly. It was great to meet you all. The pleasure was mine. Feel free to reach out to me if you guys have any questions. I'm dropping my email in this chat box right now, and I'm happy to talk to you guys about anything, whether it's medicine related or orthopedic related or life related. Feel free to reach out. It's a pleasure to meet you all.
Take care. Thank you so much.
Thank you.
Bye-bye.